Good morning, good afternoon, and good evening, everyone. Thank you for joining our ACNS YNS webinars today. Today's chair is Professor 𝒂𝒄𝒉. Professor 𝒂𝒄𝒉 is the Chief of the Neurovascular and Neurovascular Therapy Center, the Department of Neurosurgery of the Faculty of Medicine in the University of 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 Hospital in Surabaya, Indonesia. Today we have 3 speakers. Our first expert speaker is Professor Imada Sensei. He's a professor at the Department of Neurosurgery of the Mihara 𝒂𝒏𝒔 Hospital, the Hiroshima University Visiting Professor, and also in Hiroshima in Japan. We'll be talking about the transfusion approach based on the anatomical knowledge. Our next speaker is our YNS speaker, Dr. Ania Ku. He's the consultant neurosurgeon of the National Orthopedic Hospital in Enugu in Nigeria. His topic will be the autologous palsy in comminuted depressive frontal sinus fracture with a good outcome, the case report. Our third expert speaker is Dr. Muhammad. Dr. Muhammad is the neurosurgeon of the IBN Teaching Hospital. He also had a fellowship in neuroendoscopy and pelvic surgery in Mosul, Iraq. This topic will be the colloid cyst surgery. Today we have 2 discussants with us. Professor Li Zheng, who is the chief of the Neurosurgical Center Clinical Hospital in Finance and president of the Ukrainian Association of Neurosurgery. He is also the associate professor of the Department of Healthcare University. And also the next discussion is Professor Ahmed Farad. He is the professor of Kabul University of Medical Science, and he's also the chief of the neurosurgical department of 𝒂𝒏𝒔 Hospital. He's also the president of the Afghanistan Neurosurgical Society. So without further delay, I hand over to the platform to our chair today, Professor 𝒂𝒃. Please, Professor 𝒂𝒃.
Okay, thank you.
Thank you, Asma.
Yeah, nice to meet you.
Nice to meet you. Thank you.
Yeah, Professor Wadkato.
Hi.
And yes, it's a great honor for me to chair this session. And of course, thanks for your nice introduction, Dr. Ben. And I think this time we have 3 speakers, and I think the title is very interesting, and I think this will be, many discussion after their presentation. So I think Dr. Ben already introduced each of our speaker here, and I think the first session will be Professor Yasutaka Imada from Hiroshima, Japan, that he will talk about transfusional approach based on the anatomical knowledge. So please, Dr. Imada, you can start your presentation, maybe 15 or 20 minutes. It's okay. Okay, thank you. Please. Yeah.
Okay, thank you. Let's start. Thank you for giving me the opportunity of such a presentation. My name is Imada. Today, I transfusion approach based on the anatomical knowledge. Transfusion approach is most popular and important approach for aneurysm clipping. In fact, it is not easy to master this approach perfectly for some reasons. I will talk about anatomical knowledge that will help young neurosurgeons master this approach. In the prototype of the transfusion approach by Yashajiru, we usually dissect between the frontal lobe and the superficial middle cerebral vein. From now, we call the superficial middle cerebral vein SMCV. And we often have to sacrifice some bridging veins to get the wide operative field like this. However, this method doesn't provide sufficient mobility to the temporal lobe. The mobility of the temporal lobe is very important to get the operative view from the lateral side. This lateral view makes it possible to confirm the perforators behind the aneurysm. So we recommend the method of SMCV dissection for providing the sufficient mobility to both the frontal and the temporal lobe while preserving the venous structure like right figures. There are two main factors that can impede the wide opening of the Sylvian fissure. One is the Sylvian vein. The other is the adhesion of the Sylvian fissure stem. Today, I will talk about the Sylvian vein. How to dissect the Sylvian vein is a very important issue, especially for young neurosurgeons. Here we tentatively define the SMCV as follows. The front Sylvian trunk we call FST is the SMCV that receives front Sylvian vein or parietal Sylvian vein. And temporal Sylvian trunk we call TST is the SMCV that receives temporal Sylvian vein. And superficial middle cerebral common trunk we call SMCCT is the SMCV that receives both the vein from the rod and the lap at the posterior end of the Sylvian fissure. From our investigation, we could classify the SMCVs into 5 types like this. I will explain about it in detail. Type A corresponds to the SMCCT and have some anastomosis with the frontal side, like this. Type A was observed in about 60%, most frequent. And existing rate of anastomosis between the SMCCT and the temporal side was very, very low. In half of type A, the SMCCT and the TST divided into the skull base sinus separately. In half of type A, the SMCCT and the TST merge at the skull base site. So we recommend to start to dissect the temporal side of SMCCT. And then dissect between the SMCV and the frontal lobe on the base side as much as needed, like this. I will show a clinical case of type A. This case is left side IC aneurysm. This SMCV consisted of one FST, SMCCT, and one TST. This FST seemed to join the SMCCT at the proximal portion, so we judged type A. So at first, we dissected the temporal side of the SMCCT. Okay. And there was non-bridging vein between the SMCCT and TST, like this. And SMCCT and TST separated at the skull base in this case. So we could get the wide operative field while preserving veins like this. This is the pattern of dissection of type A. We recommend to start to dissect the temporal side of the SMCCT and then dissect between the SMCV and the frontal lobe on the base side as much as needed. This is the most frequent pattern. Next, type B corresponds to the SMCCT and have no anastomosis with the frontal side. This type was observed in 7.8%. In type B, we recommend to dissect the frontal side of the SMCCT, like this. Next, type C shows non-SMCCT. The FST and the TST run in parallel along the Sylvian fissure and merge at the skull base side. This type was observed in about 17%. Existing rate of anastomosis between the FST and the frontal side is very high. And existing rate anastomosis between the TST and the temporal side was high. And existing rate of anastomosis between the TST and FST is low, very low. So in type C, we recommend to start to dissect between the FST and the TST to the confluence, and then dissect between the FST and the frontal lobe on the base side as much as needed, like this. I will show a clinical case of type C. This case is right side IC aneurysm. This SMCV consisted of two FST and two TST. So we judged type C, and we started to dissect between the FST and TST to the confluence. And there were non-bridging veins between the FST and the TST. And FST merged with the TST at the proximal portion. Merged with the proximal portion. And then we dissected between the FST and the frontal lobe on the base side as much as needed. So we could get the wide operative field while preserving venous structure like this. Okay. This is a pattern of dissection of type C. We recommend to start to dissect between the FST and the TST to the confluence, and then dissect between the FST and the frontal lobe on the base side as much as needed. Next, in type D. Type D, the vein from the thorax and the vein from the lap merge at the posterior end of the Sylvian fissure, and SMCV divides into the FST and TST again toward the proximal portion, like this. This type was observed in about 13%. existing rate of anastomosis between the FST and the frontal side was very, very high. And the existing rate of anastomosis between the TST and the temporal side is very high. And existing rate of anastomosis between the FST and TST was low. So in type D, we recommend to dissect between the FST and TST, like this. These are clinical case. FST and TST divide toward the proximal portion like this. Okay. FST and TST divide toward the proximal portion like this. And we started to dissect between the FST and TST, and there were non-breaching veins. This is a pattern of dissection of type D, like this. Next, type E SMCV are undeveloped on the Sylvian fissure. This type was observed in 1.7%. In type E, we have no choice but to dissect between the frontal lobe and the temporal lobe. Okay. To summarize the contents so far, basic concept of the SMCV dissection are as follows. First, dissection to the skull base side at the main dissecting line for each type. Second, dissection between the SMCV and the frontal lobe as much as needed, like this. And even in the case of the SMCV that have complex anastomosis with the deep Sylvian veins or the temporal Sylvian vein, the strategy of dissection is not so different. First, you should dissect the SMCV according to the basic patterns. In addition, you only have to peel off the deep Sylvian veins or the temporal Sylvian vein as much as possible, like this. I will show the summary of SMCV dissection repeatedly. In type A, we recommend to start to dissect the temporal side of SMCCT and then dissect between the SMCV and the frontal lobe on the base side as much as needed. In type B, we recommend to dissect frontal side of SMCCT. In type C, we recommend to start to dissect between the FST and the TST to the conference, and then dissect between the FST and the frontal lobe on the base side as much as needed. In type D, we recommend to start to dissect between the FST and TST. In type E, we have no choice but to dissect between the frontal lobe and the temporal lobe. Although there are exceptions, this method applies in many cases. I will show a clinical case of type A again. This case is right side IC aneurysm. In this case, many veins from the torad and the lap gather at the distal portion and merge around this. That is, we judged these veins the SMCCT. And this is a FST, this is a TST. This FST seems to join the SMCCT at the proximal portion. So we judged type A. So at first, we dissected the temporal side of the SMCCT. However, it is usually difficult to dissect the SMCV on the temporal side because the SMCCT usually run on the temporal lobe, and the adhesion between the SMCCT and the temporal lobe is tight. But this dissecting line provides sufficient mobility to the temporal lobe. I'll show the video of this case. We started to dissect the temporal side of the SMCCT. And the adhesion between the SMCCT and the temporal lobe is tight. So we have to peel it off carefully and politely. In this case, the adhesion between the frontal lobe and the temporal lobe was also very tight. In such a case, the dissection of the Sylvian fissure becomes difficult because we have to dissect the SMCV and the Sylvian fissure stem with tight adhesion at the same time. In this case, we damage the pure matter around this. This is not good. And then we proceeded with the dissection of the temporal side of the SMCCT and the dissection of the Sylvian fissure alternately. Dissection of the temporal side of the SMCCT and the dissection of the Sylvian fissure stem alternately. We proceed the dissection the temporal side of the SMCCT to the skull base side. And finally, the SMCCT and the TST merged at the skull base side, like this. Moreover, the adhesion of the deep part of the Sylvian fissure was also tight. So we released the deep part of the Sylvian fissure to some extent. And then we completely dissected this common vein trunk from the frontal and temporal lobes. Like this. Finally, we dissected the residual part of Sylvian fissure in deep part. From these procedures, at last, we performed the complete dissection of the Sylvian fissure stem. And we could provide the sufficient mobility to both the frontal lobe and the temporal lobe. Now we cut the residual arachnoid membrane at the temporal side. So we could get the operative view from the lateral side, like this. Today's contents have already been published. If you are interested, please refer to them. Conclusion, these anatomical knowledge will not only help you master the transcription approach, but also help you instruct young neurosurgeons in the future. Thank you for your attention.
Okay, thank you, Professor Imada, for your, I think, a very nice presentation. And for me, it's also a new knowledge about the detail of the anatomical knowledge in Sylvian fissure. So I think this is very important knowledge for young neurosurgeon. Yeah. So thank you very much, Professor Imada, for your presentation. Yeah. So I think the discussion will be later after all the presenter send that the
Ashraf, maybe I think one by one is better.
Oh, one by one. Oh, okay.
Yes. Yeah.
Okay. Thank you, Professor Kato. So
Thank you.
yes, I think it's okay. We can start our discussion first. And I think Professor Bosniak or other colleagues, please, Professor Bosniak, you have some question?
Yeah, Professor Ashraf. Maybe okay. Maybe some questions. Maybe someone has some questions. No.
Yeah.
So thank you very much, Professor Ramada. Really, thank you very much for detailed anatomical lecture. It's really to classify the so variable anatomy of venous system of the Sylvian fish is a real achievement, and thank you for it that you just separated 5 different types and you propose the ways. Really, I'm impressed, really. But from the other hand, the Sylvian fish is still really very, very variable. And anyway, I'd advise to young neurosurgeon to collect the microsurgical tricks for this dissection, to start from hydro preparation to separation the veins from the surface of the frontal lobe, to mobilize them, then to use the excellent micro instrument. I saw you have a excellent micro scissors, excellent. Without this good instrument, it's impossible to do the professional micro neurosurgery. So my advice to young neurosurgeon to perform a lot of dissections, as many as possible, to study anatomy and collect the tricks, microsurgical tricks for micro dissection of Sylvian fish and any areas of the CNS. So, and thank you again, Professor Ramada. Thank you.
Thank you. Thank you.
Okay. Thank you, Professor.
Thank you for the comment.
You have some suggestion, Professor Imada? Okay.
Yeah.
Okay. So I think this is one question from attendee. Yeah. He asks, how do you determine the type of the Sylvian fissure? Is it preoperatively or interoperatively? Please, Yamada Sensei. Yeah.
Oh, we judged after the open the dura.
Oh, I see.
Yeah, and it is very important to look and see and observation. Yeah. After the open the dura and we look at the pattern of the Sylvian vein and we judge the type A or type C, or we judge it. Yeah.
Okay. Do you use some kind of like ICG too? For we
use ICG after clipping only. Yeah.
Oh, okay.
Yeah.
Okay. Thank you.
I believe my eyes.
Yeah. But yeah, it's very important. I think it's better if we can visualize, by our eye, just after opening the dura, so we can make sure, the type of the Sylvian vein. Yeah. Okay. Thank you. I think it's very clear. Yeah.
Thank you.
So another question is Dr. Sam Joe, please. You have
Thank you,
question, please.
Yeah. Hi, Prof. Imada. Thank you so much. I think I learned a lot from that lecture. I would like to ask, out of all the types of Sylvian fissures you have classified, is there one in particular we should think that it is best that we know before the operation, as in is a more dangerous type of Sylvian fissure compared to the rest when we are doing dissection? Thanks.
Please.
Type, yeah. But preoperative diagnosis is not so right. Yeah. MRV can't MRV venous image is not so enough to judge the type. I think. Yeah. More in detail. Yeah.
All right, I understand.
Yeah.
So you decided that the type is during your operation, yeah, during the surgery, yeah.
Yes, I think.
Okay. So is it clear, Dr. Sam?
Yeah, maybe the second part, Prof. Imada, whether any particular type of sylvian fissure where it's more dangerous compared to the rest, and where we can get into trouble if we don't do it properly, or we don't recognize that it is that type of venous drainage pattern.
Yes, Mada.
Yeah.
Is the type is maybe is very very dangerous. So we have to be careful to dissect. Yeah. What type? Yeah.
Very dangerous.
Yeah.
In type D, in type D, venous flow from frontal side to the proximal side to the distal side. I think venous flow in type D FST in many cases FST becomes the blind end at the base frontal base side. So venous flow is from the proximal side to the distal side, I think. So if I damage the FST in type D, venous infarction may be occur, I think. So be careful, I think, in type D. Yeah.
Okay. Thank you.
Yeah.
So I think it's already clear. So I think it's now Dr. Ben. You have some question?
Can I ask a quick question, because I can see so many questions in the chat box, and
yeah.
because of your very educational and very clear lectures. And I just want to ask about in acute case, in rupture case, and sometimes it's not easy to see to differentiate the types of the sylvian veins. So what can be done in your experience?
In case of subarachnoidal hemorrhage, it is difficult to judge this type. So we make irrigation with the water many times. But it is difficult in subarachnoidal hemorrhage cases. But step by step, and we dissect the sylvian vein. So gradually we can sylvian vein. Finally we judge the type. So early judgment is not impossible in case of arachnoidal hemorrhage case, I think. Yeah.
So you irrigate, to the sylvian.
Irrigation is very important.
Okay. Thank you. I think it's very clear.
I have one question to Imada Sensei. Thank you very much for a nice presentation. Once in between the two vessels, there is some small artery, that's not small vessels. How you can judge if we can sacrifice or not? Of course.
Uh,
We can
sometimes, sometimes there are very tiny bridging vein in many types. So we sacrifice the tiny bridging vein. Okay, I think, yeah.
At any time.
But main and middle venous structure is preserved.
Okay.
Yeah, thank you.
Thanks so much. Excellent. Thanks.
Okay. Thank you, Professor Ekato, for your question. And I think the many questions from the attendee. First, from Dr. Ken Obi. Thank you. Please, Professor Imadak, can a pre-op angiogram be used to differentiate the different types? Yeah. Angiogram, DSA, what do you think? Preoperative. Yeah.
Angiograph?
Yeah, do you use that?
I think even the angiograph is not sufficient, not enough to judge the type of Sylvian Bay, because there are many tiny anastomosis between the SMCV. Pre-operative diagnosis is not difficult, I think so.
Oh, I see. Okay.
But
okay, thank you. And this is another question. What is your recommendation on sharp or blind dissection to dissect the Sylvian vein? Yeah. Sharp or blind dissection? Yeah. What do you think? Do you always only use?
わかりました？
ちょっとすみません、これ。
シャープディセクションがいいのか、ブランチディセクションがいいのか、どうでしょうかって質問です。
I think so. Sharp dissection is very important, I think. Yeah.
Okay. Yeah.
In neurovascular surgeon. Okay.
So this is another question. I think it's more like how we can train to dissect the Sylvian vein. Please, which animal model is most appropriate or practical on the Sylvian approach? What do you think? A little bit different question, yeah. How do you practice?
I didn't do animal model. Sorry, I didn't.
So how you practice? Model or
how you practice?
Yeah.
It's very important to誰かな、
どうやって先生は練習したんですか？
そうなんですよ。だから、練習でも、一例一例を大事にするしかないんですけどね。one case,
so each case.
I made an effort in one case every time. Okay.
Oh yeah. So you learn by experience.
Every time, yeah.
Oh,
and after the operation, I watched my video many times.
Oh,
Yeah.
So yeah.
And make imagination. Yeah.
So you learn from your experience, yeah, during surgery.
Yeah.
Okay, thank you, Professor Mada. And then I think this is the last question. If you should sacrifice, which vein would you choose to sacrifice? Yeah, if you should sacrifice.
Sacrifice. If どうかな。 in almost cases, I preserve the main venous structure, or in almost in all cases. So I only sacrifice the tiny bridging vein. Okay. Yeah. So I don't sacrifice the main venous structure and the middle level of venous structure in every cases. So yeah.
Okay. So even a very tiny vein, is there, is how many? I think is quite safe, 2 or 3 small vein to be sacrificed or really danger, or
in many cases nothing, and sometimes 1 or 2 tiny veins only.
1 or 2, yeah.
Yeah.
Okay. Thank you. It's very important message to us. Yeah. So is there any question from the audience? I think it's very, important, yeah. For me too, yeah. For me too. It's a new knowledge for me, yeah. Okay. I think that's all, yeah, Professor Ryukato, yeah.
Yeah, I think so.
We can move to a second.
Yeah, thank you. Thank you for inviting me.
Thank you once again.
Thank you.
Yeah, thank you. Yeah. So I think we can move to second presenter, that will be Dr. Aniaku from Nigeria. Yeah. So he will talk about the autologous cranioplasty in depressed frontal sinus fracture. His experience. Please, Dr. Aniaku, the time is yours.
Okay. Yeah. Thank you so much. Thank you so much, sir. Yeah. Sorry. Are you seeing my screen?
Yes.
Yes.
Okay.
We can see the screen.
Oh, very good. Yeah, thank you so much for the opportunity. Thank you, Professor Ryukato, for this opportunity once more. Good morning, good afternoon, good evening. In everyone. Today, I'm reflects the case report, depressed frontal sinus fracture, 5 years after. The frontal sinus fracture, they are uncommon injuries of the maxillofacial skeleton. The treatment option could be conservative, open surgery, or minimally invasive approach. Complicated, severely comminuted depressed frontal sinus fracture benefits from open surgical procedure. So our Indian patient had cerebrospinal fluid leak and pneumocephalus. So he is a 39-year-old man involved in a road traffic rider motorcycle accident. He presented with alteration in consciousness of 6 hours prior to presentation. Generalized continuous headache worsened by straining of 2 days duration. Then deformity of the face with associated cerebrospinal fluid rhinorrhea of 2 days duration. He's a young man, conscious and alert, still with stable vital signs, had bilateral periorbital ecchymosis and subconjunctival hemorrhages. He had a 6/5 cm frontal depressed core fracture. Other parameters were normal. Here is the clinical picture of the patient. Yeah, here is the depressed fracture. The patient, that's the ecchymosis we're talking about. So here is the depressed core fracture. We had a CT scan that revealed comminuted depressed frontal sinus fracture as shown on the slide with pneumocephalus. Yeah. Here is the bone window with a sagittal reconstruction. So here the fracture is better delineated in the axial image and the sagittal reconstruction. Here is the 3D reconstruction of the patient's skull. You can see how severely comminuted this fracture is. The diagnosis was severely comminuted depressed frontal sinus fracture, pneumocephalus cerebrospinal fluid leak, and incidental diabetes mellitus. He had multidisciplinary care by neurosurgeon, anesthetist, endocrinologist, and the others. In the surgery, we had a bicoronal flap. As we could see here, here is the flap. This flap comminuted the frontal bone. Okay. Then had a bifrontal craniotomy, what we're seeing here. Okay. Then they had a dural repair for the CSF leak. The dural breach was identified and it was repaired. It had the exenteration of the sinus and cranalization of the frontal sinus. So, following this comminution, and in the absence of synthetic material, we had to hold the comminuted fragments together with non-absorbable nylon suture. As we can see, what is facing us here is the cranial side of the flap. And here is the following this repair joining. Here is the pericranial side, the outside of the flap with a molded flap. You can see the flap molded. So this flap, it was treated with hydrogen peroxide and rinsed with normal saline. So the bone was replaced. Here is the bone replaced. It was anchored on surrounding bones with nylon suture. What you are seeing white here is bone dust we got from the boreholes, and that is used to fill a defect, bone defect in this lower aspect. So the scalp was closed with over a subgaleal drain. The post-op was satisfactory. He was discharged 7 days after 7 days and on removal of sutures. Yeah, following repair, you can see the patient pre-op. You can see the depression pre-op. Then here is the patient post-repair. Yeah, there's some acceptable cosmesis here, but we won't take it because there's some edema which will resolve in time. So, but here it looks very acceptable. Yes, 5 years after, he had an acceptable cosmesis. Here is the patient. Acceptable, no infective complication, no recurrent cerebrospinal leak, and there was no mucocele. The challenge we had here is non-availability. It's not readily. We have synthetic cranoplastic material. They are not really readily available. And even when we find them, they are so expensive for the patients. So we had to ingeniously devise this repair method, which has worked for this patient. We equally had the problem of follow-up. When patient recovers in this part of the world, they feel all is well and they disappear. But we've been able to follow this patient up digitally, that's online. The management of frontal sinus fracture is individualized. Surgical care is employed in intracranial involvement with cerebrospinal fluid leak and pneumocephalus, and then in gross cosmetic deformity. Surgical treatment is limited in my sub-region because of the cost and scarcity of synthetic cranioplastic materials. Repair with autologous material could yield an acceptable outcome, as we see in our index patients. In conclusion, frontal sinus fractures are common in traumatic brain injuries. Prompt surgical repair in a subset of frontal sinus fracture is essential, and then appropriate patient selection is key. So on that note, I would say thank you so much for your attention. and time.
Okay. Thank you, Dr. Aniaku, for your nice presentation. And yes, this is also many problem in especially in developing country that trauma is I think is the most cases we deal every day. Yeah, I think mostly in country in Africa also have this problem, and sometimes the cost of the implant or the cost of some material that related with our surgery is also the problem. So maybe Professor Wozniak, do you have any comments or question, please?
Thank you, Professor Ashraf. Dr. Aniaku, thank you very much. Congratulations, really good case and with very good results. But I want to correct something. I want to correct that the patient you presented has a frontal lobe fracture together with a frontal sinus and with extension to the skull base. So actually you treated the frontal lobe fracture in acute period. And I absolutely agree with you. It's very dangerous to put artificial materials in patients with acute trauma. If you can postpone the plastic to the delayed period, you delay. But you cannot if you have pneumocephaly and you have to repair it. Of course, you must do it. And you must do repair only with the vascularized pericranium. Only this material is really can provide you the good hermetization of the wound. So what I say that you've done everything absolutely correct, and I congratulate you. And really, it's a really good case for presentation. Thank you very much. Thank you.
Thank you so much, sir. Thank you.
Thank you, Professor Wozniak, for your comment. And also one question I think is from the attendee. Dr. Aniaku, what did you do to the posterior wall of the frontal sinus and the sinus itself? Do you manage something for the posterior wall of the frontal sinus? Please, Dr. Aniaku.
Yeah, thank you so much, sir. The the posterior wall was removed completely, and the mucosa was exenterated. So that's the crenalization I was talking about. The crenalization is removal of the posterior wall, the posterior table of the frontal sinus. And then the exenteration is removal of the mucosa of the sinus. It was completely removed. Thank you, sir.
Okay. Thank you. I think Dr. Ben, you have any question, please?
Yes. And thank you, Niku, for sharing your experience in repairing the frontal sinus. I have some questions. I saw that during your cranial pulse, you mentioned in your presentation that you have put in some the bone dust back to the patient's scalp bone for reconstruction. So would you experience any problem with infection? What precaution that you take to prevent the infections during these cases? My second question is about the management of the mucosa. I saw you mentioned that 5 years after the surgery, there's sometimes could come back with mucosales. So how would you deal with that?
Okay. Thank you so much, Dr. Ben, for the question. Yes, infection, because this is a contaminated surgery, the sinus is open. So following the surgery, we made sure we irrigated the field with dilute hydrogen peroxide, and we even washed that bone flap with dilute hydrogen peroxide, and then rinsed with normal saline. Then the bone dust we mobilized, we washed thoroughly with hydrogen peroxide and then normal saline before we applied it. So with all this, the outcome, patient didn't come down with infection. Then the mucocele is better prevented. And we prevented mucocele in this patient by ensuring complete exenteration of the mucosa of the frontal sinus intraoperatively. Yes, sir. Thank you so much, sir.
Yes, so just want to share, sometimes when you have post-traumatic mucocele after the frontal sinus fracture, so one way to approach it is, but in ways of open surgery, you can consider supraorbital surgery, while as endoscopic, you can consider the endoscopic transorbital surgery. Sometimes you can, you might also negotiate with your colleagues because they have some sinus stent. So the sinus stent can be put inside the sinus so that they will create a channel for the drainage of the mucocele. Yes, that's my comment. Thank you so much.
Yeah, thank you so much. Thank you.
Ezra, please unmute yourself.
Yeah. Okay, sorry. Thank you, Dr. Peng. Yeah. So, yes, this is another question from the attendee. How is the cost of bone cement in your country, and what was the indication for the surgery? Is it rhinorrhea or aesthetic? If rhinorrhea, any option of endoscopic management with ENT? How about any ethmoidal fracture? Okay, please, Dr. Aniako.
Okay, yes. The actual costs, I cannot really estimate the actual costs of that synthetic material. Okay. Well, the next question, please.
What was the indication for the surgery? Is it
yes, the indication? Okay. Yeah. The indication for the surgery, actually, one was this patient had CSF leak and then has pneumocephalus. So we needed to operate to prevent the complications like meningitis. We needed to open, prevent serious complications like meningitis on the patient. So we had to go in as an emergency surgery or urgent surgery on the patient. Yes, sir.
Yeah. So is this any option for endoscopic management with ENT? No.
Yes, sir. Yes, sir. Yes, sir. There is a place for in a center with collaboration with the ENT. There is a good place for the ENT in these patients. However, we manage the patients alone. There's a good place for the care of the patients with the ENT surgeons because the CSF leak could be coming from the ethmoids. But intraoperatively, we identified the dural breach, the dural tear, and then repaired it. Yeah, thank you so much, sir.
Okay, thank you. So this is another question from Dr. Banugo. What was the patient commented on any prophylactic antibiotics?
Yes, sir. On presentation, in the surgery, pre-operatively, we commenced the patient on prophylactic antibiotics, and he received it for 5 days. Here, even in our clean cases here, we give them prophylactic antibiotics because there could be breach of asepsis, and then we wouldn't want infection. So in this patient with a contaminated injury, we offered him prophylactic antibiotics, which we gave for about 5 days and then stopped.
Okay. Yes, I think the next question is related to the previous. Is there any need for prolonged post-op antibiotics? And if, how long? Yeah.
Post-op, yes. Yes, I will give post-op antibiotics for about 4 days, not about 4 days. We give prophylactic and then we'll continue for 4 days. We did.
Okay. Yes. And the other question is, what are the options for blocking frontonasal duct post-extubation, and which one did you use? Yeah. You can understand, Dr.
Sir, thank you so much, sir. Sir. Yeah. Yes, sir.
Yeah.
The options are one can block that duct with a vascularized pericranial flap. Okay, this is one. Two, one can block that duct with fat which can be mobilized from the abdomen or from the thigh. Okay. So in the absence of this, one can equally block that duct with bone wax. But usually, it's better to either block it with pericranial flap or fat.
Okay.
These are the different options.
Yes. Thank you. And I think this is the last question. Any role of the ENT surgeon in this case intraoperative? Yeah.
No, from the surgery where there's no defined role of the ENT surgeon. Yes, sir.
Okay. Is there any question or comment, Professor Yokato? You have any comment? Yeah, please, Professor Yoko.
Thanks so much. Okay. Sir? Maybe Dr. Ben? Okay, we can proceed.
Okay. So shall I invite our next speaker, Dr. Mohammed? You can present your presentation, and then you can share the screen.
Hello everyone, thanks for inviting me. I will talk about cholecyst surgery and my experience. I will share screen. Sorry. Share my screen. Yes. Okay. Screen clear and voice also clear?
No, not yet, not yet.
We cannot see the screen yet.
Yes. Okay.
Yes, we can see it. Maybe you can go to the very beginning.
Yes. Okay. I will talk about surgical approach to cholecyst. I learned a lot from my teacher, Dr. Ahmed Adnan. Also, I learned from Professor Henry. And we will start cholecyst. We have 2% of all primary brain tumor and 20% of all intraventricular tumor. About the imaging, we have variable, maybe an MRI, hypo or hyper. Maybe the size may be small or huge and large. But the important thing we can see in CT scan, we have this hyperdense and this isodense to the brain. At the majority, it will be hyperdense, maybe due to high calcium content, and this mean the consistency of it of this cholecyst is hard, not easy to access or to remove by endoscope, and by MRI when in T2 going with CSF like in this, it's easily to access by endoscopic and we can aspirate it. About the management, sometimes we receive patient unconscious, so we need to put an urgent EVD, maybe required bilaterally. I hate shunt because shunt may cancel the rule of endoscope, so we can put an EVD and we can later on go for surgical removal of the colloid, and we remove the EVD later on, and patient not to be shunt dependent. If patient neurologically stable, so ventricular drainage not indicated even if there is a ventriculomegaly. So recommendation for removal, symptomatic patient, ventriculomegaly, progressive size enlargement, and cyst size more than 1 cm. Maybe with old age, we can follow them if the patient not symptomatic. We have a microscopic surgery, transcallosal, transcortical, and endoscopic. We have LOTA system, endoport, 𝑬𝒑𝒂𝒃 system, and stereotactic aspiration for patients not candidate for surgery, just to deflate the cyst. And about the endoscopic, it's very important, require experience and cyst location and ventricular size. If cyst we cannot see through the foramen of Monro, it's very difficult to excise the cyst by endoscope. And if the ventricular size is small or collapsed or slit ventricle, also the endoscopic may be contraindicated, and the foramen of Monro size. Sometimes we have a colloid cyst with the close foramen of Monro. So with endoscope, we cannot easily enlarge the foramen of Monro. So it's very difficult to remove it by endoscope. Also, the control of bleeding, not easy to control of bleeding that occur during the endoscopic surgery, because bleeding blurring the image, and we don't have a bipolar like in microscopic. We can control and suction and coagulate the bleeding like in microsurgery. Not all white total excision done, and local and recurrence rate is also high. So about the endoscopic, we can go, this is a Kocher point. I advise to go in front of Kocher point, 1 cm or 2 cm in front of Kocher point, and more laterally, about 3 cm from the midline. And from this area, we can go to the lateral ventricle, and to the foramen of Monro. And also we have more frontally, we can go 5 cm from the coronal suture and 4 cm. But in this approach, maybe the fornix may be at risk. We can use also this 𝑬𝒑𝒂 system, transcortical, and we enter this system, and we can enter an endoscope and bipolar and suction, and any instrument like in pituitary surgery, we can use it here. It's also good, and we can control and good hemostasis we can do by this maneuver. It's also good. I try to do some work and research on it. About the microscopic patient positioning, the patient position supine or lateral decúbitus. For me, supine look like easier, and the orientation for anatomy better. And for lateral decúbitus position, maybe we take some gravity return of brain, and we less use of retraction, but the orientation not easy like in supine position. Head is flexed from 10 to 13, depending on the location of the lesion, if the lesion go anteriorly or posteriorly. And at the beginning, I start to put the coronal suture in the middle of my skin flap. And later on, I see if I go more anteriorly, it will be more safer, and more I will be away from the motor cortex or eloquent area. So I prefer to put the skin incision as the coronal suture, the posterior limb of the skin incision as the coronal suture, and go more frontally, or I do a linear incision as the coronal suture, 2/3 as the ipsilateral and 1/3 contralateral. Always, I advise to cross the midline by the skin flap, and later on we can reflect this pericranium, and it's very important to preserve this pericranium, which is maybe needed later on with the closure of the skin or dura. And it's very important to see the coronal suture on both sides and the sagittal suture in the midline. And I prefer to do two burr-hole, one frontally and other posteriorly at the coronal, at the superior sagittal sinus. And in elderly or in young or in children, I do another burr-hole because the adherent of a dura, and I will try to separate the dura from the bone, and I do a skin cut, and I cross the midline to other side, and I will do another skin bone cut craniotomy and reflect the bone. I don't like to do the cut at the sinus because the high risk of sinus injury. Also, we cannot put a tackle suture in the falx in this way. So I prefer this or this one. If we want to do a larger craniotomy, we need another burr hole for separation of the dura from the sinus. After that, we remove, and we want to see this picture, superior sagittal sinus and the bone crossing to other side. In some cases, after we open the dura and we try to go for interhemispheric, we see this vein and we cannot negotiate between them. So when we go more frontally, we can sacrifice some small vein, but posteriorly in the middle third is very dangerous to sacrifice these vein. May patient end with the venous infarction, and I advise to do MRV, CT, MRV and MR contrast with thin slice to see these vein and to select the proper area to enter through it. We have three main veins: anterior frontal and middle frontal and posterior frontal. The surgery maybe we select from between the anterior and middle, or from middle and posterior, depending on the space between them. And in some cases, we cannot enter, so we will shift to transcortical. And this one of my case, I try to do interhemispheric, but unfortunately, I cannot pass through this vein. So I change it to transcortical, and use an endoscope. This is Layla retractors. And it's okay. We can remove the tumor, and everything is good. Also, I advise to cut the bone above the superior sagittal sinus and to cross to the other side. And we can use a suture in the falx and retract the falx and the sinus to the contralateral side. It will give us a good space to enter and to decrease the limit of retraction. So I advise to enlarge a little bit, 1 or 1.5 or 2 cm, the craniotomy crossing to other side. Also, after we enter the lateral ventricle, we will see the choroid plexus and thalamus-striate vein, anterior septal vein, and we will see the foramen of Monro, and we will see the colloid cyst through the foramen of Monro. Not in all cases, but in the majority, it's called open Monro colloid cyst. And we can, in this area, we can enter the foramen of Monro removal of tumor. And in other way, we can go in the choroidal fissure, and sometime in fornicial if the tumor split the fornices and bulge superiorly, we can do interfornicial. About the classification of choroid cyst, we have three zones. Zone 1, with the majority of choroid cyst, it will be in the zone 1, and less in the zone 2 and lesser in the zone 3. In zone 1, which extend from anterior border of fornix to the anterior septal vein, and zone 2 from anterior septal vein to the medial arterial vein. Zone 3 behind the medial arterial vein. And in the zone 1, which is the majority, we can remove the tumor or choroid cyst through the foramen of Moro, and if we need, we can little bit posteriorly through the choroidal fissure, we can enlarge the posterior end of foramen of Moro, and we don't need to sacrifice of anterior septal vein, and we can remove the tumor. But in the zone 2, we cannot do that. The choroid cyst in the zone 2, if in the midline and go between the fornices and split the fornices, we can go interfornicial. But if there is some lateralization of a tumor, we can do bichoroidal fissure and enlarge it. And the posterior limit is the anterior in the anterior, and the posterior limit is the medial arterial vein. We cannot cut that vein, which may cause some venous ischemia. Also in the zone 3, we cannot cross it, but we can go reflect the microscope, and we can remove the tumor. And also we have some article I do it with my professor, Dr. Ahmed Adnan, about a new classification of their third ventricular colloid neurosurgical classification, newly published. In this result, in this study, we found the majority is open Moro in zone 1, but in zone 2, we have closed Moro and retroforaminal and also interfornicial. In closed Moro, if the tumor is very large and go behind the fornix and push the fornix, the lateral arm of the fornix to close the foramen of Moro, and the retrofornicial if it is a small colloid cyst, not so large, and go in the zone 2, and when we go, we cannot see. We see just an open foramen of Moro, and we cannot see the tumor. The tumor is behind. And interfornicial if is in the midline and large enough to separate both fornices. This is one of my cases with big colloid cyst. There's some trick in the video I will discuss. After I open the corpus callosum here, look here for this suture in the falx, and we pull it to contralateral side. It gives a good space and good view. And also there is another benefit from it. We can go to both lateral ventricle, right and left. Sometime I will go with zoom in and try to access the foramen of Moro. The foramen of Moro in this area, I cannot access the colloid cyst. In this foramen of Moro, it's a closed foramen Moro by the colloid cyst. So I will do septum pellucidum fenestration and cut, and across to other lateral ventricle. Here I will try to open a choroidal fissure to enlarge it to access to the colloid, but it's difficult. So I want to shift to the other lateral ventricle. And from the other lateral ventricle, I will see the choroid plexus and see the foramen of Monro, and I see the colloid cyst, and we can access it from the opposite side. So here we do the surgery through both lateral ventricle. First of all, I will try to cauterize the wall of colloid cyst to make it smaller and to see the furnace. And then I try to open the wall of the colloid cyst and try to debulk and remove the content. Look here, the content, it's a little bit hard to be sucked. So it's not easy to done by endoscopic in this type of colloid cyst. I will do some escape of this video. I do debulking here of colloid cyst content. After removal of colloid cyst, here this is the floor of third ventricle. I try to do ETV, endoscopic third ventriculostomy, but by microscope. I think if we can do it, if it's better to do to prevent later on maybe hydrocephalus. This is the mammillary body of both sides. Low power, I will use low power cauterization. This is the Liljequist membrane behind the floor of the third ventricle. Also, I try to open it by dissector. This is the both furnaces, right and left furnaces, and this is the Liljequist membrane open. Later on, I will put external drain for 3 to 5 days, and I prefer to put the patient with head up position, maybe 40, 45 degree, and we increase the level of external drain. At the first day, maybe I put it at the 10 cm, second day increase it, third day increase it more, and third day I would put it about in 25 and 4 day I close it and to see the patient. If there is no any sign of increasing ICP, I will remove it and discharge patient. And thank you for your attention. I'm sorry for time.
Okay. Thank you, Dr. Nader, for your nice presentation. And I think Professor Wozniak, do you have any comment?
Okay, thank you.
From his presentation.
Professor Nader, thank you very much for great presentation, great technique, great surgery. And I completely agree with you that the transcallosal approach for the colloid cyst or the third ventricle is the best choice for neurosurgeon and for the patients. It's much less traumatic, more precise. You can do the normal microsurgery. Sometimes you have a very challenging situation when you must dissect the cyst wall from the internal cerebral vein or from the choroid plexus and so on, so on, so on. Of course, it's much better to have the 3D vision with the bimanual microsurgery. and also the endoscope, which if you operate cases with the not enlarged ventricles, it's very dangerous. You can sacrifice, you can damage the fornix and cause the very serious problems for the patient. So in this I absolutely agree, but I have one question. I don't understand. Why do you use the external drain after surgery? So what do you afraid of? What
Yes.
complications do you expect after normal microsurgery?
Yes, with dry field, the blood may be not so clear. When there's a CSF later on, a micro vessel or capillary may be rebleed. For safety, I will put a drain. Also, I put a drain to decrease ICP at the first or second day. And in some surgery, we suffer from some bleeding, cortical or from ventricle or any bleeding. For safety, I think it's important to put external drain. And if in the first day the CSF coming clear, we can close it and put it in closed 1 or 2 days and observe the patient. If there is no any sign of increasing ICP or patient not deteriorate, or if I do CT scan, I see no intraventricular hemorrhage, we can remove it from second or third day. But for majority, I advise to put external drain for a day to be more in the safe, to be more safe.
Okay. Thank you, and congratulations for great presentation. Thank you.
Okay, thank you, Professor Nek, and also Donator. And I think one question from Dr. Hu Pham. Please, Dr. Pham.
Yeah, thank you, Mohammed, for the presentation. My name is Hu Pham. I'm from Vietnam, and I have little experience with cholestasis. Most of intraventricular lesions in my department that I encountered were meningioma, central neurocytoma, and some kind of ependymomas, but very few cholestasis. My question is that is there any risk of meningitis if the cholestasis rupture naturally or intraoperatively and the component within the cyst? And how you can avoid that if there is?
Do you mean aseptic meningitis? In cholestasis, yeah, maybe occur, but I think not so common. For my cases, I don't suffer any patient from aseptic meningitis. I don't see, but it may be occur. And the treatment just steroid, not more than steroid.
Yeah, thank you.
Okay, thank you, Dr. Pham. And I think one question from the audience. What size of Vicod tube do you use for your endoscopic colitis surgery? Please, Dr. Nathir.
Please repeat the question.
What size of tube do you use?
Oh, yes. For me, I try to shift from normal endoscope to this endoport or Vicod system. I think it'd be more easy to control bleeding and to use two instruments at the same time. I use an instrument like an pituitary surgery, the same as a pituitary surgery. I can put a bipolar, I can put a sucker, I can put forceps, shift forceps. So I think it's better. We can do this Vicod system, or we can use a 20 gauge syringe. I cut the head of syringe and I put a Foley and inflate the head of Foley, and I will do a cautery at the safe sulcus and enter this Foley, and we put the syringe as a Vicod system. It's simple and cheap. Anyone we can use it, and later on we enter the the instrument through it. And by the way, this will protect the brain, and we can try to. I will use also Lotta system, the normal Lotta system, not the pediatric one, because the port larger, and we can use also two instruments at the same time.
Okay, thank you. And also one question from Dr. Sam. Please, Dr. Sam Joy.
As well. Thank you, Professor Muhammad Nadir. It was an enlightening lecture. I would like to ask two questions. First question, what about asymptomatic colloid cyst? Where do you draw the line in which it's best observed or best do surgery? So that's my first question. And my second question, it would be, what do you think about endoscopically removing it instead of our microsurgical method? Thank you.
Okay. For any symptomatic patient, definitely need surgery. But the best is microsurgery, interhemispheric transcallosal. But in all elderly patients and patients with comorbidity and cannot tolerate long anesthesia, I advise to go by stereotactic aspiration, or maybe with endoscopic, maybe a little bit more or less traumatic or less damage to the brain, but the total excision not always guarantee with the endoscopy. Okay?
Okay, thanks.
Okay. Thank you, Dr. Nadir. And is there any comment? The Professor Yokato? Do you have any
Thank
comment?
you very much. Yes, thanks, Mohammed. Thank you so much for your great experiences. So sometimes do you remain the capsule, the polycyst capsule? Sometimes it cannot be detached from the severe adherence. Is it easy to remove?
With endoscopic, yes. In some cases, I cannot remove the colloid cyst totally, because the posterior wall of the colloid cyst in the most cases is adheres to the internal cerebral vein, or this is a blind area. I cannot see it. So I cannot just pull the colloid cyst and maybe there is some bleeding. Maybe by pulling, there is some chance no bleeding and the colloid cyst coming. But if there's any bleeding happen, it will be disaster for the patient, because this internal cerebral vein may cause ischemia to the thalamus, fornices, and we cannot judge what will happen. So if I cannot remove it by endoscope, I will leave some wall of colloid cyst. But by microsurgery, no, I can't remove it totally, because I can enlarge the foramen of Morrow posteriorly. I can dissect and separate the wall totally, and I can remove it totally. So I advise to shift to the microsurgery, and it's maybe better than endoscopy.
Mm-hmm. So maybe we need a follow-up, maybe, so regrowth sometimes. But anyway, thank you very much for great experiences, conversation.
Thank you.
Azra?
Okay. Okay. Yeah. Okay. Thank you, Professor Yokato, for your question. And I think there are no more questions. So I think it's been a great, great presentation from the three speakers. Thank you once again for Dr. Imada, Professor Imada, and Dr. Anyaku, and also Dr. Nadir, and also Professor Yokato, and also Professor ৱ্যসনিak. It's been a great, great webinar, and I think new knowledge and then you can share experience to us, especially for young neurosurgeon. And before I end this session and give back to Ben, I want to share something. Yeah.
Yeah, sure. Please, that's what please share.
Yeah.
We're still waiting for it. Yeah.
You can see my slide?
Not yet.
Not yet. Waiting to be shared. It
Yeah, okay.
takes a little bit time. Yeah, now it's okay.
Dr. Ben? Yeah, yeah. So just want to, to remember again that the 2027 World Congress of World Federation of Neurological Society is it's held in Bali, Indonesia. So you are most welcome, and I hope you can visit our country. Okay, thank you very much.
Oh, congratulations.
Yeah.
Thank you. Thank you.
Thank you
Congratulations.
very much. Okay,
Thank you.
So see you next time. Please, Ben.
Okay.
Yeah,
Please,
so
Ben.
just the last word. Of course, first of all, congratulations as well for holding the event. And also, I would like to thank you today for Professor Yamada Sensei and also Anya Sensei and also Ahmed Sensei and for the great lectures and really a great discussion today, very educational. And thank you, Alexei, for your time to be here to discuss. You raised a very important point as well. So of course, my colleagues, Dr. Fan, and other panelists on this, and thank you so much for coming the event. So again, it's a bye-bye to all of us, and I'd like to see you all to the next ACNS YNS webinars, and also ACNS YNS Continental webinars. Stay tuned for the time and schedule. And oh yeah, Roger is here, and thank you, Roger, for holding the event as well. Thank you so much. See you next time.
Thank you.
Okay. Bye-bye.
Bye-bye.
Boss,
Thank you.
thanks very much.
Thank you very much. Thank you.
Bye.
Bye-bye. Thank you.
Thank you.